Good morning, everyone, and welcome to today's webinar, the Quality Payment Program Year 2 Final Rule and Beyond. My name is Kelsey Baker, and I'm joined by my colleague, Tushara James. We work for Health-Centric Advisors, part of the New England QIN-QIO, and we are both program coordinators for the Quality Payment Program tab, and we will be discussing the Year 2 Final Rule today. So this is just a disclaimer that while our company is contracted by the Centers for Medicare and Medicaid Services, CMS didn't create these slides, but we at the New England QIN-QIO did. Okay, so for today's webinar, we'll be focusing on the Year 2 Final Rule, some changes in eligibility criteria, submission mechanism, the new virtual group, performance categories and scoring. We'll also touch upon alternative payment models. We'll have some resources for everyone to use, and we'll leave some time for questions and answers. So as you all likely know, CMS loves acronyms, and we've put together a little cheat sheet for reference. Some of the important ones to note are APM, or Alternative Payment Models, CMS, which is the Center for Medicare and Medicaid Services, MIPS, the Merit-Based Incentive Payment System, QPP, or Quality Payment Program, and ACI, or Nursing Care Information. Okay, so let's just jump right in and get started. So, as you all know, the final rule for Year 2 was published on November 2nd, 2017, and this is the final rule with comments. So the final date for submitting any comments to CMS is January 2nd, 2018. So please, if you or your organization have any specific comments you would like to submit, please do so and use the following code to do this. All right, so who is eligible for MIPS? So the general eligibility criteria hasn't changed in the Year 2 rule. So it's still physicians, which of course includes MDs, DOs, podiatrists, dentists, and chiropractors, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists are eligible for this reporting. The low volume threshold did, however, increase from $30,000 in Part B claims annually to $90,000 in Part B claims annually. And it also increased from 100 Medicare patients to 200 Medicare patients a year. CMS stated that they increased this threshold to reduce the burden on small practices, and by increasing this threshold, it would exclude many from the program. And clinicians in their first year of submitting Medicare claims or who are participating in advanced APMs are also excluded from this, so this is the same as last year. So I'll briefly go over the specialty status for non-patient-facing clinicians. So this criteria remains the same for individuals and groups. So for individuals, they must have 100 or fewer patient-facing encounters, and for groups, they must have 75% of the NPIs billing under their QIN to be considered non-patient-facing, for the group to be considered non-patient-facing. Now for a virtual group, it is basically the same as a regular group. So 75% of the NPIs in the virtual group must be considered non-patient-facing, for the virtual group to be considered non-patient-facing. Okay, so CMS had originally included in the proposed rule that they are going to allow multiple submission mechanisms within performance categories. However, that did not get finalized in the final rule. So it still remains that only one submission mechanism is allowed per performance category. So for example, using one mechanism like EHR Direct for the quality category. CMS did state that they would allow multiple submission mechanisms within a performance category for year 2019 and years after that. And so the submission mechanisms and reporting options still include registry, the QCDR or Qualified Clinical Data Registry, claims, attestation, EHR, or CMS web interface for groups of 25 or more, and CAPS or MIPS, which also is for groups. So as you can see here, the individual and group submission mechanisms for each performance category remain the same for 2018 as they were for 2017. Now you'll notice that cost is not on this list, even though cost does account for 10% of the MIPS final score for the 2018 performance year. CMS will pull that data directly for you, So there is no direct data submission required for that category. Okay, so virtual groups are the new hot topic for the Year 2 final rule. So virtual groups were created to help reduce submission burden on clinicians and help clinicians receive a higher incentive payment if it is applicable to them and can be helpful to them. So a virtual group is made up of solo clinicians and or groups, no matter the specialty or location, with 10 or fewer clinicians, meaning that there should be anywhere from 1 to 10 NPIs in each TIN. A virtual group may be based on appropriate classifications, such as geography or specialty, or they could just be friends from medical school. It doesn't matter. For the virtual group, all MIPS-eligible clinicians within a TIN must participate in the virtual group. So if my TIN is joining a virtual group, but individually I might not have had to report, my data is now being pulled in because I'm part of that TIN that is joining the virtual group. Also, a group can only be in one virtual group and can't split between different virtual groups. The entire virtual group must use the same submission mechanism for each category, and for now, all clinicians or groups within a virtual group will have to have the ability to use the same submission mechanism. So if you're using EHR, you just need to make sure that everyone in your virtual group has that same EHR technology. And for now, there is no restriction on the overall size or total number of clinicians for a virtual group. So to be in a virtual group, you must elect to participate in one prior to the beginning of the performance period. And this election includes a written agreement that must be submitted to CMS. CMS will define a model agreement and provide templates for groups to use. The deadline for electing was originally December 1st, but CMS has actually pushed that to December 31st. So if you plan on participating in a virtual group for the 2018 performance year, you must elect to do so by December 31st, 2017. If you elect to participate and the performance period begins, once you do that, you must participate in the virtual group for the entirety of the performance year, and that can't be changed. Also, just a quick note, if a TIN or MPI is in a virtual group and in an alternative payment model, the TIN or MPI will receive a final score based on both the virtual group and a final score on APM, but their payment adjustment is based off of their APM score, not the virtual group score. So CMS has identified 2 stages for virtual group election. So stage 1 includes contacting your local QPP technical assistance organization, like us at Health Centric Advisors, to see if you are eligible to join or form a virtual group. Now, if you don't go that route, you can participate in what they are calling stage 2 and contact CMS directly for your eligibility determination. Okay, so I'm now going to hand it off to my colleague, Tushar James, to tell us more about performance categories and scoring. So, Tushar?
Thank you, Kelsey. MIPS 2018 performance categories. The 4 categories for MIPS in performance year 2018 are quality, which accounts for 50% of the total score, which is currently 60% in 2017. Advancing care information accounting for 25% of the composite score. Cost weighing 10% of the final score, which is 0% in current performance year, and improvement activities comprising 15% of the score. As mentioned on the previous slide, quality comprises about half, that is 50% of the MIPS composite score in performance year 2018. It will go down to 30% in 2019, and the minimum performance period for quality category will be 12 months. That is from January 1st, 2018 through December 31st, 2018 next year. Again, data completeness threshold would increase to 60% for the data submitted on quality measures. For all submission mechanisms using QCDRs, qualified registries, via EHR, or Medicare Part B claims for the 2018 performance period. Web interface and caps are excluded from this. Measures that don't meet the data completeness criteria will earn only 1 point, except for a measure submitted by a small practice, which will earn 3 points. Top-out measures will be removed and scored on 4-year phasing out timeline. Those topped-out measures with benchmarks that have been topped out for at least 2 consecutive years will earn up to 7 points. Again, 3-point floor for measures with benchmarks and bonus points are also available in this category. Now, cost performance category. CMS has finalized that the cost performance category would comprise 10% of the MIPS final score for the Quality Payment Program Year 2. This is to ease the transition to a 30% rate for the cost performance category in 2019 performance year. And the performance period for the cost category will be 12 months, that is from January 1st, 2018 through December 31st, 2018 next year. For 2018 performance period, CMS is adopting the total per capita cost for all attributed beneficiaries measure and the Medicare spending per beneficiary measure. And CMS will no longer be using 10 episode-based measures that were adopted in 2017 MIPS performance period, but it's in the process of developing new episode-based measures with significant clinician input. Improvement Activities Performance Category. There are no changes in the Improvement Activities category scoring for the Quality Payment Program Year 2. Improvement Activities category comprises of 15% of the total MIPS score. Eligible clinicians need to report on 1 to 4 activities depending on their practice size. There are medium and high-rated activities earning 10 and 20 points respectively. CMS has also added more options to this category, and there are approximately 112 activities available to choose from. Certified PCMH practices earn full credit for participation in this category, but CMS has introduced a minimum 50% threshold for the number of practice sites within a chain that needs to be medical owned to receive full credit. Advancing Care Information category. For the Quality Payment Program Year 2, the ACI performance category is 25% of the final score. MIPS eligible clinicians may continue to use 2014 certified EHR technology for the performance year 2018. Clinicians may choose to use 2015 certified EHR version or a combination of the two. Clinicians will earn 10% bonus points for using only certified 2015 certified EHR technology. Similar to previous year, failure to report on the base measures will result in 0 scores for the ACI category. Bonus points are available, and again, significant hardship exception is also available for struggling practices. CMS is finalizing the exclusions for the e-prescribing and health information exchange measures beginning with the 2017 performance period 2. MIPS scoring. How the final score is calculated. Scores for each performance category will be weighted and rolled up into MIPS final score. The weights of each category may increase or decrease in subsequent reporting years. MIPS composite score is calculated by combining the scores earned from each performance category and multiplying it with 100. Performance threshold and payment adjustment. Performance threshold. CMS has finalized a minimum performance threshold of 15 points for the Quality Payment Program Year 2. This is a substantial increase from current performance year, where the minimum points required to avoid a penalty is only 3 points. Those who receive more than 70 MIPS points will be eligible for exceptional performer bonus on the top of budget-neutral payment adjustment. The payment adjustment for QPP Year 2 ranges from -5% to 5%. Payment adjustment. For Quality Payment Program Year 2, ECs who earn 70 or more MIPS points will receive a positive payment adjustment, including exceptional performer bonus, that is a minimum of 0.5%. Again, those who receive MIPS points ranging from 16 to 69 will earn a positive payment adjustment, but not an exceptional performer bonus. Those who receive 15 MIPS points will receive a neutral payment adjustment, and a score of 0 will be subject to a 5% penalty. Performance period. Minimum performance periods for MIPS categories are as follows. Quality and cost categories, 12 months. Improvement activities, 90 consecutive days. And advanced care information category is also 90 consecutive days. CMS is implementing additional flexibilities for small practices for year 2, including increased low volume threshold, which might exclude a lot of small and solo practices from MIPS reporting. Adding 5 bonus points to the final scores of small practices. Again, giving them choice to form or join a virtual group to participate with other practices in reporting. Continuing to award small practices 3 points for measures in quality performance category that don't meet data completeness requirements. And adding a significant hardship exception for advancing care information performance category for MIPS eligible clinicians in small practices. Now the APM highlights. We are not getting much into the details of this section. The highlights include incentive lump sum payment remains at 5% for QPP year 2. Requires at least 50% of the eligible clinicians to use certified EHR technology. And a 4th snapshot date will be also added, that is December 31st, to determine the participation in full-time MIPS APM. CMS won't be using the 4th snapshot date to make QP determinations or extend the QP performance period past August 31st. All MIPS APMs will follow the same category weights. The weights are quality 50%, cost 0%, improvement activities 20%, and advanced care information 30%. Here are some useful resources. Please visit our website, New England QIN-QIO macro website for more resources and updates on the QPP program year 2. The next link takes you to the CMS Quality Payment Program website, where you can find more about the QPP program. You can check your eligibility status using the entire lookup tool and more. We have also attached the link for CMS QPP year 2 final rule executive summary.
Okay, and before we get into some questions, we just wanted to talk about our Learning Center or our virtual learning system, which hosts free courses available to all healthcare providers. So as healthcare providers, we know that you have busy schedules, so courses are laid out in bite-sized chunks, and some even have continuing education credits. For example, you could take a free test and begin a lesson during a break, or on the next day you could continue the lesson, as the system will ask if you want to start where you left off. It's mobile friendly, so you can begin a course at work on your computer and continue on your tablet or phone at home, or when you're out and about, like waiting for an oil change. So in order to keep things up to date and relevant, courses are reviewed by subject matter experts, and we also welcome feedback from users. So if there's a course topic that people want to see in the future, we have surveys in place to capture those requests. Providers can expect to see courses sorted by healthcare setting, but they're not restricted from any courses except our internal staff training. Managers can get reports on their courses that their teams are taking, the number of times, the pre- and post-test responses and grades, and any relevant feedback that's captured. And this can be helpful in identifying gaps or opportunities for reinforcement of training. So we invite you to visit the Learning Center at learning4quality.org and follow your healthcare settings instructions for creating a new account. If you have any questions, please send an email to learning@healthcenteredadvisors.org for assistance. Also, don't forget to follow us on social media and get important alerts, news, and more. Thanks for joining, and now we will take any questions folks have. You can actually type them right into the chat, or you can hit #6 on your phone to ask them via the phone. Okay, so we have a question in chat. If you qualify for an exclusion for the ACI category, how is the final score calculated? Do you just get a 0 for the category? So if you qualify for an exclusion for the advancing care information category, that will roll over to quality. So your quality category will account for 75%. So that's for any ACI category hardships that you apply for an exclusion for. For non-patient facing clinicians and hospital-based clinicians, it would just be 0. So, and quality is 75%. So I hope that answered your question. We have another question from Ann. What is the new low volume threshold for 2018? So the new low volume threshold is $90,000 annually in Part B claims and 200 Medicare beneficiaries annually.
Hello.
Hi, how are you?
Hi. Good, how are you? My name's Jonathan.
Good, thanks.
I have a question about the folks. It's more for 2017 than 2018. Are you entertaining questions for 2017?
Well, sure. What is it? We'll see how we count.
We're in MIPS APM rather, and with the ACO, and we have that window from 8/31 to 12/31, and we've got some providers in there, and we have 2 TINs that we report on through our MSSP. And the members that joined post 8/31 are part of that EPN EPS TIN. And we're curious, do they qualify for, how do we report them?
Hi, Jonathan.
Hi.
So those clinicians that join either of your 2, the EPN or EPS TINs after 8/31, they would have to report MIPS individually. So they could still be part of your group, so take advantage of the group reporting aspect, but they're reporting under MIPS, not under your APS.
Okay, so
yeah.
they would be qualified for the group threshold as far as 30,000 and 100.
Yeah, exactly. So they're basically seen as individuals because of coming into the APM after that 3rd snapshot date.
Yeah, I was thinking of doing the crawl option and just doing like one quality metric for each of them. And
yeah, absolutely. You can do whatever makes the most sense for your organization. You're not required to do anything more than that single measure if you want to avoid the penalty.
Okay. All right. You said you can take advantage of the group. They're part of the group. What do you mean by that?
Sure. So in the group setting, so let's say how many clinicians on average? There's about 100 specialists and 50 or so primary cares under each TIN, correct?
Roughly, yeah.
So let's say you have, 5 new clinicians joining the EPN TIN, so the primary care group, and they want to report as a group because 5 is easier to report as a group rather than individual. You could consolidate all of those 50 clinicians' performance in whatever measure or measures you select for that time period for that 5 set, not for the entire group. You're pulling all of the data for the entire group, but only applying to those 5 clinicians that joined after that 8/31 snapshot date. They just get to take advantage of the fact that maybe their performance is lower, and with the participation of all of the clinicians in the group, they could actually pull their performance up and maybe get a higher positive change.
Okay, I follow now. So even though we take an aggregate score for the whole ACO and report that as a group, we would take our EPN, EPS TIN performance and use that for the 5 or so, or 12, whatever it is, that we post 8/31. Okay, I follow.
Yeah, and only those clinicians, those separate from the APM, would get the MIP adjustment. The ones that are part of the APM still fall under the APM and with the APM adjustment.
Thank you so much for your help.
Yeah, absolutely.
So it looks like we have some more questions in chat. So Lisa wrote, how will the final rule apply to provider offices that operate on paper charts and not on EHR? So for any offices that don't have an EHR, they will receive a 0 score for the advancing care information category. So it doesn't necessarily mean that you'll get a penalty as long as you report on quality and improvement activities and your costs. It would just affect your score. So And small practices actually now for the Performance Year 2018 might qualify for the Advancing Care Information Hardship. And so someone actually also asked where they can find information about that. You can find it on the qpp.cms.gov website. It's all right there, including the application for that hardship. So if you go on, you can find it there. I hope that was helpful. So Jen asked if a practice is eligible this year but does not meet the low volume threshold for next year, are they exempt? So if the practice is eligible this year, they need to report this year. If they don't meet the low volume threshold for next year, then they would just be exempt next year. But for this year, if they meet that, then they do need to report. So Rose also asked, is it safe to assume that pathologists who do not actually see patients are excluded? I would definitely not say that it is safe to assume that. So pathologists or any clinicians can actually type their NPI onto the qpp.cms.gov website, where there's a specialty status table that will tell them if they meet the eligibility criteria to be a non-patient-facing clinician, or if they're hospital-based, or they're considered a small practice. So any clinicians who are unsure can check on that website. Is there any quick resources available to see if we meet the 90,000 threshold? So there is, next year you will be able to see that, but however right now, if you went on to that qpp.cms.gov website to see if you are, if you need to report or not, it would show you if you need to report for 2017. So you will need to check next year to see if you meet the low volume threshold for Performance Year 2018. Yeah, and maybe not, like January 1st, but maybe a few months into the year, and hopefully we'll have more information on that later. We aren't 100% sure yet. I hope we are answering everyone's questions.
So Amy asked a question about the ACI exclusion, so regarding the health information exchange and the summary of care measures. There were two exclusions finalized in this final rule. The first was for the health information exchange / summary of care, electronic summary of care measure. So clinicians that have fewer than 100 referrals or transitions of care during the reporting period would be excluded from reporting on that measure, and that is retroactive to the 2017 reporting period. Similarly, for the e-prescribing measure, clinicians that have fewer than 100 permissible e-prescriptions during the reporting period are also excluded from reporting on that measure, and that is also available for the 2017 reporting period. We have had a couple of questions about the way that it was written into the final rule. It does appear that CMS is saying that this exclusion is only by the individual clinician, even if you're participating as a group. So we've had questions where clinicians are saying, okay, so if I'm part of, let's say, a 5-clinician group, all of the 5 are excluded. Does that mean that our group practice is 0-0 because we're all excluded? We've actually reached out to CMS for clarification on that, so more to come. But my anticipated answer is that CMS just worded that in a way that is confusing, but in fact the whole group would be excluded if all of the clinicians are in fact excluded.
Okay, so I'm actually going to put in the chat box the link to the QPP CMS website for any individuals who want to see if they're eligible or that specialty status. And it's also right here on our resources page. So does anyone else have any other questions they'd like to ask, either in the chat or you can do #6 and just ask us? Hi, so the question from Helen, there will be a transcript available in about a week, and the slides from today's session will also be available. Thanks, Morgan. So, yeah, Morgan just put the link to where the slides and the transcripts can be found right in the chat box.
And there will also be a recording added to that same area, so you'll be actually able to listen to, the presentation today and watch it with the advancing slides. So it will all be there hopefully within a week.
All right, so we'll give it a few more minutes, but if no one else has any other questions, we'll close the line at 12:10. And here's my contact information and Tushara's contact information for anyone who has any specific questions they want to send over. Hi, so for Anne who just asked, she checked an NPI, got an error message. Is that because they're participating in a MIPS APM? So no, Anne, that NPI should have been listed, so I would just double check that the NPI is definitely correct. It's not, a misplacement of a number, but it should be there. And it's individuals, not practices, so it's just each individual clinician. You're welcome. Hi, so Susan just asked if hold on. So the question that was asked by Tricia, is the exclusion for e-prescribing available in 2017 reporting period, 100 or less? Yes, that is correct. It is retroactive to the 2017 performance period. Hi, so Susan just asked if we wanted to report through a registry, where would I find one that's certified? If you go on that qpp.cms.gov website and go to the resource library and follow the tab, it'll bring up like a new page. There is a list of qualified registries on that page, like all the way at the bottom. So just keep scrolling through, you'll find it. So Marika just asked if we are excluded in 2018 for low volume, will there be a payment adjustment? So if anyone is excluded for the 2018 performance period, they are totally excluded from the program. So there won't be any negative payment adjustment or positive payment adjustment. They will just be excluded. They won't have to report. So I just actually put the link to the resource library, so in case anyone wants to go and check, the link is right there in the chat. So Marika just asked, what is the benefit of joining a virtual group? So it's actually completely up to the participant. For some, it might benefit you, and for some, it wouldn't. Sometimes it's benefit to join a virtual group, so you're just doing one data submission, and you can benefit from others' data that might be helping your score. So it just depends. Some folks who are in rural parts of states might benefit from joining a virtual group to have collaboration with colleagues who might have ideas on workflows that can help support some of the measures that they might not have, wouldn't have been available to them. So it just depends, but there are some benefits for sure. Okay, so Susan just asked, are there any changes in the MIPS categories for 2018? So as Tushara mentioned earlier, cost is now included. So cost accounts for 10% of your final MIPS score, and quality now accounts for 50% of the MIPS score. So the weightage is different, and also cost is now included in that. So there are some other changes we went over. I don't know if you wanted a more specific answer, but hopefully that helps. All right, so if there are no additional questions, we can close out the call. I don't see any in chat. So I'd love to thank everyone so much for joining us today. It was a pleasure. Again, our contact information is here if you want to reach out and email us or call us with any questions. And the slides are available on the link in the chat, so please feel free to use them, and the transcript should be available shortly. Is there anything that I'm missing, Morgan?
Just as people close out of the webinar today, the evaluation will automatically pop up on their screen. So if we could, if you guys could fill that out, we would greatly appreciate it. And we will be sending out an email tomorrow that will contain a link to the event webpage where you'll find the presentation, transcript, and recording. And it'll also have a link to the evaluation in case you don't have time to fill it out right now. That's all I got.
Great. Thanks, Morgan.
No problem.
All right. Thank you, everyone. Have a great day.